That the SARS-CoV is a zoonotic pathogen with the possible spillover directly from the wildlife or via intermediate animal host or their products like rodent and rat and some of the fish food it was in Wuhan. There was sustained human-to-human transmission has been confirmed in China and to all the world. So as I said, the coronavirus is a member of the coronavirus family, and there are more than 40 coronavirus identified can cause illness in the human and animal, and only 7 strains can cause severe disease in human. The 3 coronavirus like MERS-CoV, SARS-1 and SARS-2, and the other common cold coronavirus. So total 7 out of 40 coronavirus can cause human disease. This is again, they are divided to alpha, beta, gamma, and delta. And only 7 strains it was in blue, it can cause disease, 2 in alpha, which cause common cold, and the beta, the more severe form. So during the genetic testing for the viruses, they saw similarity between the SARS-CoV and MERS-CoV and the new novel coronavirus SARS-CoV-2 in the spike, which is in the red one, which is important as a part of the attaching to the host cells, and the only different mainly in the green part, which is the membrane protein and also the genomic RNA. So this is important in using the treatment regimen. So all the data and clinical trial based on the previous SARS-CoV and the MERS-CoV pandemic. So they try to use the same antiviral what was used previously because they are same structural genetic testing. So the coronavirus enter the host cells. This is the human of the host cells through the ACE2 receptors in the host cells through the spike, then go under in the endosomes and go into the cells and go a lot of multiple steps till assembly of the new virus, starting from the translocation, cytosis, and transcription, and the translation and assembly. Each step of the virus replication, it is important to target the antivirus therapy. So when we define a suspected case of COVID-19, the Ministry of Health and the WHO, they have the same definition. You have 3 clinical presentations when you suspect COVID-19. Either patient, number 1, with patient with acute respiratory illness, like sudden onset of at least one of the following fever, either measured or history. So the measurement not really need, even if the family give a history of fever, consider suspected with cough or SOB, and there is no epidemiological link is required if this patient they came to the ER. Or any patient will have sudden onset of at least headache, sore throat, diarrhea, nausea, or diarrhea without fever, and in 14 days prior to the symptoms, they have at least meet of the following criteria. This is in the green one. They should have contact with confirmed COVID-19 case or lived in or worked in facility known to be experienced an outbreak of COVID-19. The third definition, any patient came with acute respiratory distress syndrome, any patient they came with community-acquired pneumonia or hospital-acquired pneumonia, they are highly suspected to have COVID, and there is no other criteria should be met. When we say confirmed, the same definition of the suspected, but you have positive laboratory confirmation of the COVID-19 infection, which is real-time PCR. The contact, it is very important to define what is the definition of contact. First, you will be being with 2 meters of a confirmed COVID-19 case for more than 15 minutes, direct physical contact with a confirmed COVID-19 case. You are providing direct care for a confirmed COVID-19 patient without you using proper PPE.
Admission
with a confirmed COVID-19 case, or you are sharing the same room or eating together in the same restaurant with a confirmed COVID-19 case. sitting within 2 rows in any direction of a confirmed COVID-19 case for more than 15 minutes at any crew in direct contact with the case in a public or shared transportation. So this is the visual triage. I think it is famous for everyone. This is the updated one in May by our hospital, and it is adopted from the Ministry of Health. So this is the exposure risk, and you are giving the score. If any patient have close contact, you will give him score 3, or contact with camel, you will give score 3, and if he had a visiting facility or working in facility within 14 days before the symptoms, you will score 13. Then they divided to pediatric and adult based on the clinical sign and symptoms. If any fever or history of fever, you give score 4, cough score 4, and SOB score 4, or headache, sore throat, or anuria, you give score 1. In nausea, vomiting, or diarrhea, score 1. Chronic renal failure and other chronic disease, you will give score 1 in adult, and they did not include pediatric. I don't know why. And any patient with score more than 4, it is highly suspected to be COVID, and you have to test for MERS-CoV and COVID-19, and you have should give the patient surgical mask and follow the policy for suspected cases. So pediatric infection of COVID-19, they are unique and different. They are very less common incidence, around 1.7 in USA and less than 1 in China, and there is no data in Saudi Arabia for total confirmed case. And they are less severe, about 0.58 to 2% of the total ICU admission. They are from pediatric, and they have less mortality. They say less than 2% of the total mortality worldwide, they are from pediatric cases. And the symptoms almost, they are the same. So the patient, the pediatric, this is a study done from the CDC regarding the symptoms of pediatric infection compared to the adults. They are included all the cases, about 10 or 11,000 patients between 1894 and 291 pediatric age. Almost they are similar. But mainly they present diarrhea, abdominal pain, they have less headache, and the common presentation is fever or the triad, fever, cough, and SOP. Although the COVID-19 can cause other symptoms like dysregulation response, cytokine storm, and immunodepression, can cause organ dysfunction with sepsis-like, can affect any organ, either respiratory system, which cause ARDS, hematological system can cause coagulopathy, and immune system, cardiac can cause MI, and also GI system can cause intestinal gangrene, or abdominal pain can cause stroke, encephalopathy, and also can cause acute kidney injury. So regarding the management, I will focus mainly on the management approach for pediatric by Ministry of Health. Before starting, all the management and the guideline used to assess healthcare practitioners to select the best available antiviral therapy for COVID-19 infection according to the best available and current evidence. It is not intended to replace a clinical judgment, but rather to complement it. We should involve the family for treatment plan, and we should have high index of suspicion, and we have to think about other differential diagnoses of fever like meningitis, urosepsis, and bacteremia, etc. Regarding the management, there is no evidence from randomized clinical trials that any potential therapy improve outcome in patients with either suspected or confirmed COVID-19. There are no clinical trial data supporting any prophylactic therapy. More than 300 active clinical treatment trials are underway. Regarding the focus management, we have general management, treat symptoms, give hydration, and we will use paracetamol and avoid ibuprofen and other NSAID, and the specific antiviral therapy. Regarding the NSAID and the use and uncertainty about the use, there is no clinical or population-based data address the risk of NSAID. There was negative effect of NSAID raised by report for a few young patients who received NSAID early in the course of infection and experienced severe disease. With given the absence of data, the European Medicine Agency (EMA) and the WHO do not recommend NSAIDs to be avoided when clinically indicated. So this is again the viral replication and focus on the type of therapy. We can see here the SARS-CoV with the spike. Once it attached to the host cell, the ACE2 receptor, the first step, it is attaching to the transmembrane receptor 2, and we can use some medication like Comstate, Misalate to prevent its adherence, or once the membrane fusion, we can use chloroquine or hydroxy. And here the most important step, which is RNA-dependent polymerase steps, are many of the antiviral therapy and the clinical trial is going on to prevent the replication and the last step of the viral entry. And as known, the SARS-CoV can cause activation of inflammatory response, where the tocilizumab can act and bind to IL-2 receptor and prevent activation and inhibit IL-6 signaling. So first, hydroxychloroquine and chloroquine, a lot of data and social media, they recommend to use chloroquine. Then the many studies, they retracted from the publication. Then finally, the WHO and the FDA not recommend to use hydroxychloroquine and chloroquine as emergency use for SARS-CoV-19 infection. And although it is still recommended by Ministry of Health as the last medication, and still in the guideline of the Ministry of Health protocol, it was published in 17th of June. So how it works, it's blocked viral entry by inhibiting the glycosylation of receptors and prevent the endosomal acidification, and also act as immunomodulator effect through inhibition of cytokines, as we can use in SLE. Should be avoid chloroquine and G6PD. We have to use with caution in diabetic patients because can cause hypoglycemia and can cause fatal cardiac arrhythmia, mainly in adults. The other medication which was removed from the Ministry of Health protocol for pediatric, it is the combined medication of the two antiviral, lopinavir and ritonavir. It is Calitra, which is the famous medication used in HIV patients. There cannot be used as a monotherapy, and is still using in adult protocol by triple medication with interferon and ribavirin. And still some hospitals, they are still using in pediatric Calitra with some good effect, but all under trial. The withdrawn cannot be used in patients with renal failure and can cause irreversible hepatic impairment. The new medication, which was now available in our hospital and all Ministry of Health hospital, is favipiravir. It is like nucleoside analog. It is prodrug, need activation and inhibit the most important step, which is RNA-dependent polymerase. And it is approved in Japan for treatment of influenza viruses A and B and C, and also used in Ebola with very good outcome with decreased mortality. And currently it is still under investigation, and it is used still under clinical trial, and we have to discuss with patients and should be written consent. And the recommendation of Ministry of Health will use mainly with mild to moderate disease and can cause good improvement of the viral replication and clearance, and also improvement of the X-ray and prevent the progression of the disease. So used mainly in mild or to moderate disease. So here the active form, favipiravir, it is prevent the replication, so it will decrease the viral load and increase the clearance and decrease the X-ray finding. The adverse reactions of the favipiravir can cause very bad GI disturbance like gastritis, and all majority of the patients, they cannot tolerate the side effect, can cause increase of the liver enzyme, can cause significant neutropenia and dose-related asymptomatic hyperuricemia, and it is contraindicated in pregnancy because it is teratogenic. The other medication, it is remdesivir. Unfortunately, it is still not available in Saudi Arabia, and not FDA, not Saudi FDA approved. It is investigational drug. They use in mild to moderate to critical cases, and they are a lot of contraindicated with increased. You cannot use in multi-organ failure if the patient he need introp, if they have creatinine clearance less than 30, and if the patient he require dialysis, hemoinfiltration, or he had high liver enzyme more than 5 times, and you cannot use with other antiviral therapy, mainly Calita. The medication tocilizumab, it is immunomediator medication. It is bind to IL-6 receptor, used in critical cases with evidence of cytokine storm syndrome, and need require dose adjustment of patient with hepatotoxicity to perform IL-6 and other inflammatory marker testing prior to the start like CRP, ferritin D dimer, and can cause very bad infusion reaction. And it is available in sub-Q injection. The other medication, it is really promising, like steroid. It is not recommended unless there are other indications. There was associated with increased risk for mortality in patients with influenza and delayed viral clearance in patients with MERS-CoV infection. But now the recovery study of the randomized evaluation of COVID-19 therapy, which was published in the news on 16th of June, they mentioned that dexamethasone reduced the 28-day mortality rate by 17%, with a highly significant trend showing greatest benefit among those patients requiring ventilation. So it is not no benefit in patients without oxygen. They are good in patients with required ventilation, and they are severe pneumonia, and used only in hospital setting. And the follow-up in the study was over for about more than 94% of the patient. And now the Ministry of Health, they recommend use of dexamethasone in severe and critical cases in their recent protocol. The other medication is still not approved for pediatrics. It is interferon beta. It is approved for adults. The effective reduce in MERS-CoV in vitro and has resulted in good outcome in the animal models of MERS-CoV infection. And also the other medication like azithromycin with chloroquine, there's still study and clinical trial undergoing, and but there is no benefit and maybe increased complication. You can check the ongoing trial on the registry of the international clinical trial, can be found on the WHO website and at the clinicaltrial.gov. Regarding the second part, the newborn, there is no evidence for intrauterine vertical transmission of COVID-19 from infected pregnant mother to their fetus, and well known that an infected mother can transmit the COVID-19 virus throughout the respiratory droplet during the breastfeeding, and COVID-19 is not known to cause any fetal congenital anomaly. So once the baby delivered with the suspected or confirmed mom, the immediate separation should be done. Direct breastfeeding is not advisable. We will use express breast milk. Precaution measures are to be strictly followed: washing hands and the breast before doing the express breast milk, wearing face mask for the mother, using a clean breast pump, clean the surface of the milk collection container, and another person should feed the baby. And we'll do nasopharyngeal swab PCR for the baby after 24 hours. And if the mother needs to be treated, not all medication safe for the neonate for the breast milk. Our experience in our hospital, as we know, we have everyone involved in the pediatric COVID team, including the pediatric ER, the pediatric assigned COVID team consultant, the pediatric infectious disease, the pediatric team with all the subspecialty, and the PICU with cooperation with the family medicine and the infection control. We have assigned the pediatric surgical room to suspected cases and confirmed We have one negative pressure room assigned to confirmed cases or if need nebulization, or any role degeneration procedure. And we have two rooms in the surgical ward assigned as in-house on-call room for the COVID-19 resident. And we have a separate local room assigned to a changing room. A team of 2 to 3 consultants and 6 residents are teamed to provide coverage for 2 weeks until the end of pandemic. We are doing PPE huddle for 10 minutes implemented in the daily handover. SPAR, we discharge patients if they are asymptomatic, and we are giving them follow-up in the virtual clinic daily, 7 days a week, even the weekend, with daily phone call and follow-up by the pediatric COVID team. And if the patient needs to reassessment again, we call them and we readmit again the patient. And this is our pathway. Currently, we have almost a total of more than 100 patients pediatric confirmed. Majority of them, they are mild or symptoms, and no one they have pneumonia, and all they are doing well in during the virtual clinic follow-up. To conclude, even though children tend to have mild form of COVID-19, does not mean we should ignore those who have the disease. We need to take measures to prevent them becoming infected. We also need to bear in mind that the virus can persist in feces longer after they are absent from nasopharyngeal secretion. So if the patient is still on diaper, we give instruction to the family during the importance of the hand hygiene during the diaper. And in some studies, they mentioned they can stay up, almost 1 month after negative from nasopharyngeal PCR aspirate. Thank you.
Take it, Dr. Bandar. Ahlan fi.
Okay. Thank you very much. Hello, everybody. Good afternoon. Thank you for giving me this chance to talk about the pathway of the year and how we are dealing with the pediatric patients who land in the emergency department. It's like a practical way, so that I'm not sharing more slides. Yes, I'm going to talk about the general pathway, what we have expected, and how we deal with patients coming from the emergency department. So we'll start to talk about initially how we receive a patient in the pediatric emergency department. So we are receiving the cases and the pediatric emergency department from many referrals. The first one is the patients may present to the emergency department. This is the first way. The second way from the screening centers. The third way from the family medicine or the family clinics, and from other primary cares for the military part. So once the patient was received in the pediatric emergency, we are making the setup for the pediatric emergency in 2 ways. Actually, we have divided the pediatric emergency into respiratory zone, and we have also what's called the regular bed. So in the pediatric respiratory zone, we have like an 8 beds, and we have 2 HEPA filters is there. So once we receive a patient in the pediatric emergency department, we are doing a visual triage. There is a visual triage. This visual triage is at all the gates of the pediatric emergency. So once we receive a patient, either from the screening center or from the other clinics or from the family medicine, or the patients land in the ER, so there will be a visual triage. This visual triage, the aim of this visual triage is to decide by scoring system that has been modified by the COVID committee in the hospital in regards to the MOH recommendations. So the aim of this triage is to divide and guide the patients. Either these patients will go pushed to the respiratory zone, or this patient will go to the regular pediatric emergency pathway and care. So when we have a patient's individual triage, how we gonna score him? The scoring system will be divided into two parts. The first part is the exposure risk, and the second part is the clinical signs and symptoms. So if we have okay, so if you have now the patients coming to the pediatric emergency, first questions will be asked is the exposure risk. Three questions will be given for the exposure risk. The first question is the patient has been exposed to confirmed COVID-19 in the last 14 days. The second question is the patient was exposed to any camel or a camel product, direct or indirect, in the last 14 days. The third question is, does the patient is living in facilities where there is an outbreak for the COVID-19 in the last 14 days? Any answer of these questions with yes, this will score as 3. Then we will go for the second assessment at the visual triage, which is the clinical signs and symptoms. And this has been changed many times according to the situations and according to the number. We are getting the data from the wiqaya, from the MOH, has been modified many times, and we are informed actually regularly with this update, so we can deal and change our protocols and our rules. So in the last guidelines, the clinical signs and symptoms, for the fever, we are giving score of 4. For any cough, we are giving the symptoms score of 4 also. For any shortness of breath, we are giving also a score of 4. Then we have the other things like vomiting, nausea, and diarrhea, score only of 1. If they have sore throat, if they have headache, if they have runny nose, they will score for 1. So at the end, after we calculate the exposure risk and we calculate the clinical signs and symptoms, if the patient scoring 4 or more, that means he is highly suspicious to have a COVID-19 according to this scoring system. That means we are going to put a surgical mask on the mouth of the patients and clean the hands, and will be guided by the nurse immediately to the respiratory zone if he is less than 6 months. Because if the patient is more than 6 months, he will be shifted directly to the screening center from the visual triage in the ER, unless this patient is having a risk factor. So at any age, if the patient is a highly risk factor classification, for example, he have chronic diseases, for example, he is having like sickle cell disease, chronic renal failure, other chronic respiratory disorders, cardiac patients, those no, whatever the age, regardless, will be seen in the pediatric emergency department in the respiratory zone. But if the patient is stable and he is more than 6 months, no risk factor, will be guided to the screening centers. So this is the pathway how we are going to deal with. Again, if the patient is less than 6 months, should be seen regardless in the respiratory zone in the pediatric ER. If the patient is more than 6 months, now we are going to ask the question, is he having chronic diseases? Yes, he is going to be seen in the pediatric emergency department respiratory zone. No, he is going to be sent to the screening center. Now, what we expect now if the patient is coming to the pediatric emergency department, now the other questions for us as a physician and nurses, is the patient is stable clinically or no? If he is unstable clinically by the visual triage, this patient should be shifted immediately to the code room there, where full PPEs will be taken, and the patients will be assessed there with all the precautions that we know for the COVID-19, and then will be managed further by the ABC's protocols, and then will be guided either to be admitted to the ICUs people or to the pediatric COVID ward. But now the other questions, if the patient is stable and coming to the pediatric emergency departments and in the respiratory zone, once the patient is shifted to the respiratory zone, the nurse there will notify the doctor, and the doctor will take all his precautions inside. He will go in, he will wear his PPEs, and will examine the patients, and then we will decide according to the patient's condition there inside. If the patient is clinically stable, we will do for him chest X-ray, and we will do the COVID-19 swab. Then if he is stable, the X-ray is fine, the number of the patients will be taken and will be sent home to the to do the home isolation, and will notify the preventive medicine, the infection control, and the preventive medicine rule will start now by contacting these patients daily to be sure that he is doing his home isolation and he is clinically fine. And at any time they think that this patient is now unstable, they will call him back to come to the hospital. But if the patients remain contacted daily with the preventive medicine and he's doing fine, they will guide him with what they expect to do in the home isolation, what are the signs and the symptoms that give them red flag to come back to the emergency department or to be admitted again. So this is the rule of us. Now, if we want to do the admission, we have an isolation room in the pediatric emergency department. All the swabs will be done and the X-ray on the isolation room. No swabs and no chest X-ray will be done for any patient suspected COVID in the respiratory zone without the good precautions and without doing the negative pressure room to take the swab and to do the X-ray there. Then after that, the patients can be shifted back to the respiratory zone safely, and then we will decide as a physician, either if he's stable, he can go home for the home isolation as I just mentioned, or if he needs admission, that time there is a very cooperative and arranged COVID team on call daily, consists of the residents and consultant pediatric. They are responsible for only managing the COVID-19 suspected or confirmed cases. So they have leave, which is very well known for the COVID team on call, and they have the communications with them. The patients will go through the pathway from the respiratory zone to the COVID area. After arranging with the COVID team, they will receive the patients and do their pathway there in the pediatric ward. The aim of us in the pediatric emergency is to apply this visual triage strictly and apply the pathway strictly, and to ensure that all our staff, nurses, physicians, housekeepers, and all the pediatric ER team to be strict to this measures to avoid any outbreaks, la samahallah, or to avoid also any transmission risk for the patients and for the staff. So this is in summary how we are managing patients from the time he lands to the emergency department, and how we assess him in the visual triage, and how his pathway from the respiratory zone or the screening center to be sent, and then lastly his pathway as he is going home or he is going to the COVID pediatric ward by arrangement. So all the elements is arranged and well organized, and alhamdulillah, we don't have a lot of problems. Meanwhile, in the beginning of the crisis, as you know, there is a lot of debate and a lot of negotiations, but alhamdulillah, all this negotiation, with the time we learn, with the time we put our rules, with the time we are discussing all the teams, alhamdulillah, pediatric ward, the pediatric emergency, and the COVID team, all we are working in the same wavelength. We give them always our notice, and they give us their feedback, and we try at the end to make it very easy and very smooth. And our aim all from the pediatric ward or the pediatric emergency to keep all the staff and the patients safe, and they journey from home to the
talk about in the ventilation strategies. So if you have our patient who is intubated with severe ARDS in pediatric ICU, we should aim lower level of plateau pressure, less than 28, lower target of pH to 7.15 to 7.3. Tide volume should be adjusted according to the lung compliance. If there is poor lung compliance, we should target 3 to 6 ml per kg. If there is good lung compliance, we should target 5 to 8 ml per kg with a better preserve compliance. Patient who has moderate or severe ARDS, higher PEEP always recommended. Please try to avoid disconnection of the patient from the ventilator, as could result in the recruitment of this patient. Prone ventilation should be considered in the patient who has severe ARDS and still with refractory hypoxemia. Always use the inline catheter suctioning for airway suctioning. If you reach to refractory hypoxemia and organ failure that require ECMO, please discuss this decision with the expertise in the ECMO field prior to convincing patient to this decision. Fluid management on this patient with severe ARDS should be initially conservative, especially on this patient who has no hypoperfusion. Patient with moderate to severe ARDS with BA2 and FI2 ratio less than 150, neuromuscular blockage by continuous infusion should not be a routine use, and we should adjust this to the need. I'm gonna move, hopefully everything also good with the voice, to management of those patients with septic shock. First, once we recognize the septic shock with hypotension or end organ dysfunction, altered mental status, bradycardia, tachycardia, oliguria, increased lactate, we should consider the septic shock, and we should initiate our fluid management as needed on those patients. And when we don't need, we should avoid the extra fluid to this patient. If there is no response to this fluid management, consider initiation of early vasopressor in this patient. I'm gonna move to the quick view over the protected intubation in those patients. We have many steps, we're gonna go over them quickly. So keep in mind always, in those patients, intubate the patient early is better when he deteriorates clinically. Appropriate protective equipment as per institute strategy for those patients, and please ensure the safety of healthcare worker. Minimize the number of people inside the room as much as you can. Intubation must be done by the most experienced provider. Try to use always self-inflating bag only. Use filter when you do ambu bag if needed. avoid the nebulized solution unless you are in airborne precautions. Rapid sequence intubation with paralysis, always recommended on the patient with COVID-19. Prepare your patient before you go inside the room. So if you have this patient, you should put enhanced precaution signs on the door. Move your patient to the negative pressure room. Place protection when performing arousal generating procedure sign on the door. As you can see here, we immunize the people to the intubating physician, RT, RN, and another RN if needed or recorder, in addition to the standby people outside the room. Prepare the equipment, including the incubation cart, intubation protective equipment cart, intubation and resuscitation medication should be ready and prepared inside the room with the ventilator. All of this equipment here should be ready inside the intubation room for any need during the time of intubation. It always prefer to use disposable gyroscope plate and laryngoscope with a MAC plate. Try to use always cuff tube and end-tidal CO2 disposable one for the examination of your intubation successfulness. Hopefully we have still good voice. Identify minimal personnel required in the room for intubation, as we mentioned earlier. Identify individual required outside the room to support your team. We should have another experienced MD outside to support the intubating physician. We should have experienced RT, senior RT, with the charge nurse preferred doing this procedure outside the room, and always keep a runner who can support the team with any equipment needed inside the room. I'm gonna repeat this. We have the intubator physician here, RT inside the room. We have the first respiratory, we have the first registered nurse inside the room, and we could have another recorder or a nurse to support the nurse. We're gonna have the runner outside the room with another MD outside the room. Keep in mind, we have to do our first time out for the patient outside the room. So prior to entering patient room, individuals to be in the room complete time out with their shadow partners. Nurse and RT or physician are in patient room, therefore this time out will be repeated in more details for each part of intubation plan and the roles of each person in the room. And it's really helpful to reassign the jobs and to detect the deficient equipment, instrument, and the needed equipment for the intubation prior to enter the room. Second time out, inside the patient room, teams don the PPE supervised by their partners enter the room and repeat the standard pre-intubation huddle at the patient bedside, clearly in the identifying each person roles and double check the presence and the readiness of the equipment. During the procedure of intubation, standard enhanced precautions intubation procedures with the most experienced MD, and the door should be closed. These procedures can result in infection in anyone who is not taking his precautions. Team in the room in BB accomplish as many remaining patient care tasks that could be arousal generating, such as opening suction, endotracheal tube change, and filter placement. Team should be with the BBE all the time. And if there is any defect happening in the BBE, the backup person should be coming to the room with releasing another one, informing the team leader that there is a change happening in the room. This shouldn't happen during the exposure of the airway. Team enrolled of the PPE and exit should be observed by partner all the time. This is a summary for the process of intubation in the airborne precautions. So as we mentioned, we'll start with PPEs, then we'll prepare our equipment and prepare for the worst scenario and difficulties that could face. And then the second time out should happen inside the room. And then we're gonna proceed for the exit and the safety of our patient. We're gonna listen for this video quickly to go over this process.
Our concept is divided in 3 phases. We have the planning phase, intubation and extubation, as well as post-operative care. All these phases are equally important. First, we have the planning, and as you can see, we are all donned in protective gear, which is according to your local SOPs. We did our body check and we deemed each other appropriate for this procedure. For induction, we have our medications on the tray, as well as our airway materials, including an endotracheal tube with a stylet in place, as well as our video laryngoscope. Next to the induction table, we have our dirty tray for dirty materials to be disposed there. It's also important to have a trash bin next to the patient so you can drop dirty articles right into the trash bin. Outside, we have Tim, who is our clean person and jumper in case we need medications or airway material. He will be able to hand them to us. We designated our roles clearly, with Larissa being the medication person and airway help, Manila doing the documentation, Tim outside as a clean person, and myself as a seasoned anesthesiologist doing the airway. We are starting with an adequate pre-oxygenation for about 3 to 5 minutes. As you can see, our patient is wearing a surgical face mask, which of course we have to take off. Then we will pre-oxygenate, and here it's important to have a tight-fitting mask to avoid any leakage. After a thorough pre-oxygenation, we are starting our rapid sequence induction. RSI is used to avoid backmasking the patient for prevention of aerosolization. Here, avoiding coughing with a thorough relaxation is also of utmost importance. We induce the patient and our patient is paralyzed. We are now intubating the patient with a video laryngoscope. We are utilizing an endotracheal tube with a stylet in place. The endotracheal tube now is in place. The stylet can go. Thank you. It's important to inflate the cuff before ventilating the patient. If a patient is desaturating and you have to backmask the patient, it is very important to use both hands to backmask the patient, to have a tight seal, and have a second person, Larissa in this case, to backmask your patient. If the backmasking is not successful, it is important to then reach out to the person outside the room and gather other aids. For example, LMA. If you have to escalate to a fiber optic scope, please use a single-use fiber scope. Intraoperatively, we are utilizing lung protective ventilation strategies, i.e. a tidal volume of 4 to 6 cc's per kilogram ideal body weight and a PEEP. If you're transporting an intubated patient to the ICU, make sure that you clamp the endotracheal tube in inspiration before you disconnect and reconnect to your back valve mask. We are saving our transport ventilators for use in the ICU, and hence currently we are utilizing bag valve masking for transportation of ICU patients. Our concept is divided in 3 phases. We have thank you. It's important to inflate the cuff before ventilating the patient. If a patient is desaturating and you have to backmask the patient, it is very important to use both hands to backmask the patient, to have a tight seal, and have a second person, Larissa in this case, to backmask your patient. If the backmasking is not successful, it is important to then reach out to the person outside the room and gather other aids, for example, LMA. If you have to escalate to a fiber optic scope, please use a single-use fiber scope. Intraoperatively, we are utilizing lung protective ventilation strategies, i.e. a tidal volume of 4 to 6 cc's per kilogram ideal body weight and a PEEP. If you're transporting an intubated patient to the ICU, make sure that you clamp the endotracheal tube in inspiration before you disconnect and reconnect to your bag valve mask. We're saving our transport ventilators for use in the ICU, and hence currently we are utilizing bag valve masking for transportation of ICU patients. Our concept is divided.
We're gonna go back about quickly now after the presentation of the airway. We're gonna speak about the algorithm for the COVID-19 update. Should be a quick one. It's the update of the American Heart Association. I just want everyone to understand with me the major concept in these changes. So, and those PLS, the change happened in those patients that after we verify the scene safety, we should don our PPEs and limit the personnel inside the room. After that, during our assessment of patient, if we need to do the risk of breathing, we should use the bag mask device with a filter and tight seal. This is a major difference in the BLS with single score or with the double score. I'm gonna let you see this video in managing the quick PLS on those patients.
No response. Help. I'm going to get transfer. This is the whole look. I'm at the scene. Scene is safe. I have donned the PPE. A limited person at the scene. The technique for unresponsiveness. Sir, patient is unresponsive. Taking of pulse and the breathing. 1001, 1002, 1003, 1002, 1005. No pulse and breathing. So starting chest compression. 1, 2, 3, 4, 5, 6, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 29, 30. Coming to the respiration part, I've attached no filter, final filter to the arm bag. I will ensure that the mask is tight sealed, and I'm going to give 2 ventilation. And I'm going to continue this process till I get some help.
So hopefully the video was clear voice for everyone. The main message in this video that I want to deliver: always use a vital filter during the ambo bag with a tight seal when needed. The second thing, it happens in many occasions, especially for those who is in pediatric ward, they will call you to restate the patient. So the restation should be started by the most available healthcare worker, and the toning is a priority for the protection of healthcare worker, as per the new interim guidelines of American Heart Association. So please take your time to don your PPE before jumping to your patient. Even in the case of arrest, the nurse or the person who recognizes the event can start the CPR till you have a full donning before you start. For the pulse guidelines, it is available in yellow color. It is the same like before, but they add always first, done your PPE and limit the personnel inside the room during the recitation before you start. Then we're gonna proceed with the same algorithm for the PCR for the CPR during the arrest. And once we have the intubation ready by the most experienced with full PPE, it should have a priority even before the shock. So you should pause the chest compression for intubation. If intubation is delayed, consider the supraglottic airway or bag mask device with a filter and tight seal to avoid the risk of infection for the healthcare worker. Connect to the ventilator with a filter again when possible. So this is the current update, as I mentioned for you regarding the pulse, make priority for intubation. I know during the event of resuscitation, the people always in hurry want to jump in to intubate. Once you don't have the PPE or the viral filter and the equipment, please review your equipment before you start, as we mentioned in the video before. I'll use to say that during our COVID-19, together, we have found a new way to support each other and deliver our mission of education, research, and medical service. And together, we will overcome the challenges we face in COVID-19 pandemic. Thank you for listening and attending, and I'm ready for any questions.
Start the CPR if we recognize cardiac arrest, because it was not clear if we put the PPE first or we start CPR till someone put the PPE.
Dr.
So
Haider,
we have
if,
not to start CPR till they put the PPE. This is
CPR in the pulse or the new interim guidelines. Before anything, even assessment of the patient, start CPR before it, don your PPEs. Yeah. So your priority healthcare worker is priority. That's why they did the interim guidance to change the American Heart Association. So
So the total number of children tested for COVID-19 is 305, 87, and these are children under 12 years of age and below. 87 were positive, and this would be like 28.5% of the population that they were tested at KFAFH. They came of the child age group. They were positive. Of course, this is not a prevalence because we're not doing, kind of population testing. These are the only population that came to us either because of symptoms or because, they've been identified, somewhere else with contact. And if we look at the distribution, 44 of them are female, 43 are male, and 23 they are newborns that they were born to COVID-19 suspected and, or confirmed mom. We have 4 out of the 23, we have 4 confirmed moms. But you know what, all the babies, they were tested negative. So if we can go back to the, it seems that, yes, yeah. If we can just talk a bit about the overall of how to do the, I don't know, I think I lost my way. All right. Sorry about that. No, I think we're going to go back. All right. So what I'm going to do, I'm just going to take, an overall. It's not specific for the pediatrics, and we're going to try to avoid, the repetition Dr. Ru'a has covered the case definition and, for the COVID-19 and the merits as well. So we're going to focus more about infection control. And we know that, it has been, pandemic has been, declared on the 30th of January 2020. It has a strong human-to-human transmission. It is caused, by a virus from the corona family, and the transmission can be droplet, contact, aerosol, fecal-oral, maternal and infant vertical transmission. It's not very well documented, and it's going to be discussed by the NICU team on next Wednesday, because there is a lot of controversy about about the transmission, about the breastfeeding. So they're going to have a session on Wednesday, next Wednesday, inshallah. So now, we've talked about the case definition, and the incubation period is 1 to 4 days. And the symptomatology in general could be asymptomatic infection. And now if you open, the internet, you find that there is a lot of symptomatology: fever, fatigue, dry cough, upper respiratory, GI, insomnia, loss of taste, and loss of taste buds, and as well, ability to smell. So it can be anything and everything nowadays. And these are the different, kind of responses that it goes. First, we have the viral response, and then, stage 2 is the pulmonary phase, and then stage 3 is the hyperinflammation. And, the hyperinflammation response is seen more in the elderly population, and that may be one of the reasons why they get more of acute symptomatology related to ARDS, and that's maybe an explanation why in children they don't have this hyperimmune response. So that's why in children we don't see, a severity of illness. And the fatality, case fatality, as you can see, it goes higher with the age. So till the age of less than 50, it's 0.29%. But it goes up to 15% in age group of 80 plus. And of course, the more comorbidity, whether it's in the children age or in the older age, that carries a higher fatality. And, it could be mild, moderate, the clinical presentation, mild, moderate, severe, or critical. And this is A, B, C, and D. And, most of the mild and moderate, they end with recovery without, kind of passing through the ICU. But still, there is, a certain percent, a small percent of them that, unfortunately, they go into the ICU, and, a small percent that they die. But the severe and the critical, they're more likely to be in ICU admissions, and, the fatality is high. And unfortunately, now we see more patients in the severe and critical. So we are now having more patients that they require intensive care, support, admissions, and they require ventilatory support. So this is what's covered by Dr. Ru'a about the case definition, whether it's in adult and in child. And I need just to emphasize the MERS-CoV. The differences is that there is contact with camels. And, one of the CURP 65, it doesn't apply to the pediatric age group, but this is an important criteria that it's linked, with the MERS-CoV, because it kind of estimates the severity of illness or the pneumonia, in the adult group, and it actually helps in the decision to admit. So if the score was 0 to 1, then that patient will be treated most probably as an outpatient, because the mortality, 30 days mortality is 0.72%. The higher the score, the more likely that the patient would be admitted, to to the inpatient care or even to the intensive care with a higher mortality, 30 days mortality. Now, what do we investigate? Investigate with the CBC, C-reactive protein, liver enzymes, and we detect as well the virus. And how we detect the virus, we detect it with the PCR through a nasopharyngeal or sputum or bronchoalveolar lavage fluid, which is more likely to detect a higher rate of positives. But overall, the nasopharyngeal swab is like 50%, positivity, and this is how it's being done. And this is interesting that it actually talks about the relationship between the prevalence and the prevalence of the COVID-19 in the population, and then the positive predictive value of the PCR testing. So the higher the prevalence, the more likely the positive predictive value of the test. It goes up to 88.5% if the prevalence of the COVID-19 is 30%. And if we do 2 samples instead of 1, then that goes to nearly 100%. So the idea is that if you have a high index of suspicion about a patient, that this patient is behaving as COVID, then even if the first PCR was negative, I think it's worth repeating it again, because as we've seen, the PCR is not really it's kind of a 50% positive even in cases who have the disease. There is another tool that has been identified, which is the antibodies, but there kind of vagueness about its use because maybe the combination of doing the PCR with the antibody testing, I think that would have a better positive predictive value. So we have 2 types of antibodies, the IgM and the IgG, and maybe the combination of them would help later on when we start opening up for elective surgeries, elective procedures. So I think for the healthcare worker as well as for the patient, it would add a value to know whether your patient is immune and the healthcare provider as well as immune. And now, if you look at the hierarchy of controlling the COVID-19, elimination would be the best, which is isolate yourself and just stay at home, but that's not possible. You have to go to work. So if you can do your work at home, then be it. If not, then you have to check your vitals and check your symptomatology. And the others that they share the space with you. If anybody is having any symptomatology, should be reported, and maintain the distance for 1 to 2 meters while talking to people. And this has been of concern in some of our, of our colleagues. They said, okay, during doing rounds in pediatrics, people have the tendency to cluster the nursing station, and maybe we should not do that. We should keep our mask on, and as well, we have to keep a social distance and just address our patients and minimize gathering. Also for our junior colleagues, the on-call room should not be a place where we socialize or we share our meals this time. That's not the right time to do that. Minimize the exposure, keep your social distance because the spread of the infection is quite high. And of course, keep your PPE, it's very important. And there are stories from our hospital where actually cross-infection has occurred because people did not keep their social distance. They sit and they share meal, and they got infected with that. So please, please, please keep your social distance, keep your mask on, and minimize gathering. Now, the disease can make anybody sick, regardless of their race or ethnicity. the immediate risk of becoming seriously ill from the virus that goes is thought to be low. If somebody got the infected, finished their quarantine, and they're back to work, that's not a stigma that nobody should come near them. Well, they're immune. They're less likely to spread the disease, to be infected, to be infectious for the others. There are simple things: wash your hand, wash your hand, wash your hand, wash your hand. And I'm so grateful for our engineering, because they provided the department with sinks, and that would facilitate the hand washing by all the staff. Then avoid touching your eyes, nose, and mouth, and stay home when you are sick, and cover your cough and sneeze with tissue, and throw the tissue in the trash. And you could see when you climb the stairs or even walk in the corridors, you find that there is a lot of kind of napkins there, and also mask that could be a source of infection. So how can we help? By stopping the COVID-19, by knowing the signs and symptoms, and by avoiding all the previous things that we've said. Keep distant and avoid social gathering. Now let's talk about the exposure risk and the epidemiological risk factors. So if there is a prolonged close contact with COVID-19 patient who was wearing a face mask, okay, and the healthcare worker was having his mask on, then the exposure category is categorized as low. But if the healthcare worker was not wearing any PPE, then he or she at a medium exposure risk. If they are not wearing a face mask, then medium. If they are wearing, if they are not wearing eye protection or gowns and gloves, then that's lower than not wearing a face mask. So a face mask is very important in decreasing the exposure risk. So if we take a prolonged close contact, and what is defined as prolonged is 15 minutes, 20 minutes, with COVID-19 patient who was not wearing a face mask. So if the healthcare worker is not wearing the face mask either, then the exposure risk is really high. So please keep your mask on. This is from Belgium, one of the, ICU, not ICU, COVID-19 hospitals that they were done in an old, barn. And in Jeddah, as you know, the Al-Harthi has become, has been providing hospital care for COVID patients as well. Please, can you review the infection control manual? There is a good description of the antiseptic and the disinfection policy at KFAFH. And pay attention to your surrounding, because this is very important. Look at, the disinfectant, the bleaches, whether cleaning is being done or not. Don't go in and out with your clothes into the COVID area. You need to change your clothes before you go home. And also the brooms, we talk about the mops, the red mops, remember, they are assigned for the COVID area. So we don't want to see any red mop in the non-COVID area, because this means that there is cross-infectivity and infection. And also the disposable clothes, rugs, we should not reuse them again from one area to another. And then remember, we need to break this chain of infection spread. The infection agent has a reservoir and a mop, for example, portal of exit, mode of transmission, portal of entry, susceptible host, and then the circle goes on. What we need to break it by pay attention for all the details. Now, environmental cleaning involves two main types of surfaces, the environmental surface and the medical equipment. And if you look here, the light switch is one of the highly contaminated, as well as, the wheelchair, the ECG cart. And of course, if we go into the, bathrooms, the commodes for patients is contaminated, as well as all the handles. all right? And moving to the equipment that more in use, which is the ear examination. You know, how often is being used by different hands? Did they wash their hand? Did we clean it before we actually use it? The same with the echo machine, the same with even the simple computer keys through which we enter our, and we check the lab and all this thing. You know, this is, we have to develop the habit of just, you know, clean it with a tissue impregnated with alcohol or chlorine in order to disinfect it. So cleaning, when it's done, it physically removes rather than kill the microorganism. But when we are using the disinfectant, we're actually killing the most of the microorganism. And we have to remember that even our housekeeper, they should wear their PPE when they are going after the patient is discharged and they want to go a COVID patient, and especially if that patient was you know, was in a negative pressure because of nebulization or because of aerosolized, you know, management or type of the disease, then there is more likely that that whoever goes into the room is at risk for, you know, for getting infection if they don't have their PPE in. Now, this is very important because, and it's actually, it has even a value because the contamination level differs according to the size of the room and according to the level of, you know, of ventilation and the concentration of the contamination. So these are values that they are measured based on the concentration of contamination, airflow rate, and the room volume. And you could see that the time that it's required for the removal of the virus from that area varies from 1 hour and 38 minutes to 6 minutes only. So it's important to, for even the support services when they go in and out, or when we go in and out in the room after, you know, the patient, after it's evacuated, to make sure that, you know, at least 30 minutes to an hour has elapsed before they go in, especially if it was, you know, aerosolization or a negatively pressured room required according to the patient needs. And if we look, this is, you know, the contamination area, and most probably these areas are forgotten if we don't pay attention to it. And here, the linen is clean, but unfortunately it was, yeah, the nurse or who changed the linen forgot to change the gloves. So this means that even the linen would be contaminated. And just a reminder, the COVID-19 carries all the contact, droplet, and airborne, and that's why it's not enough to have PPEs like that or like this. It has to be a combination of all. And I want to share with you some of the disinfectant, and this is from the environmental, from the APA. Which is actually, it looks at the different, it has a list of the disinfectant and how they are effective against different viruses or bacteria. So you see the isopropyl alcohol, the Clorox, the sodium hypochlorite, and the hydrogen peroxidases are effective against the human coronavirus, and they can disinfect the place, or they can kill the virus within between 2 to 6 minutes. So, you know, they are effective and they should be used frequently as a disinfectant. So basically the healthcare facility infrastructure should harbor, you know, a policy for disinfectant, and that disinfection should be more and more emphasized during the COVID-19. And it's part of the infection control actually to go around and make sure that cleaning is done even every 4 hours, and the terminal cleaning is being done when the patient is discharged. So as you can see, it's not a Hollywood, so you don't need to keep your gloves and mask after you leave the room. Ideally, you should really change them. So when you go into the room, on the patient's room and come out, you need to change your gloves, and you need to change as well as your mask. And the same thing, I've seen really a couple of our friends, our colleagues, that they walking around with the mask below their nose. I don't know what's the value. It's really useless. So let's look at what are the important PPEs. Hand hygiene is the most important, really, tool to prevent infection. Just let me remind you that this corona is actually a crown that comes from those protein spikes. Okay, so it makes it like a crown. And the corona has these spikes that they are made of protein, and then inside the envelope is made of lipids. And that envelope is the one that carries all the yucky parts of the virus that when they are disseminated into the cell, they are infecting, the body. And if we look at the soap molecule, it has two ends. One is the hydrophobic, and the other one is the hydrophilic. So this hydrophobic attaches itself to the lipids, and then it disintegrated, while the hydrophilic part, it's attached itself to the water molecules. So hence a destruction of the virus takes place by just washing a hand for 20 seconds. See how easy it is? So please, 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 please wash your hands as frequent as you can. Now, hand sanitization is equally good. And if we just can do it all again, you rub your hand, rub it on the back as well. You place it around the whips of your fingers, and then, you do the tips, and you do the tips, you do the tips, you do the tips, the thumb, and as well as the wrist. So it doesn't really take time, only 20 seconds. That's what's needed. And why the sequence of this? Because the fingertips is the place where most of the organisms are there. And remember, there isn't really a big difference between the soap or sanitizer. The difference is if you use soap and water to remove the dirt, if there, God forbid, there's blood or body fluids, then it takes 30 seconds to probably clean and dry the hands. And remember as well, if you touch those areas that they are highly contaminated and they are not really white, or they are not clean, then you're going to recontaminate your hands, even if you washed it. So it's kind of keep an eye on what's going around you and make sure that you are dealing with the clean surfaces as well. And, cough etiquette is very important. We don't need really to share our sneezes and coughs. We can put our arm on it. And it's really sad that when you go around and see all these tissues and all these contaminated masks on the floor, I think they are a source of infection as well and should not be there. Okay, so what are the barriers? Gloves, just ordinary glove, you don't need to double. Actually, according to the Oxford evidence base, when we have double gloves on, we have a problem with the donning and the doffing, and there is more likely to cause infection for ourselves. And these are the different type of barriers that we have the mask. So we have a surgical mask, we have the N95 mask, and I hope all the pediatric department, they are tested N95. If they don't have a fit test or beard and they don't want to part from their beard, then we have the respirator, and at the moment it's available in the hospital and should be provided for you before you cover your COVID team coverage. The gowns, they are just the simple yellow gowns. And, this is about the N95 testing. So how to wear it, it's very important to kind of take the lower string, you put it, you cup it in your finger, and then you pull it in the back of your head, and you make sure that it's fitted well. And, donning and doffing is very important. So you put first the, gown in, then the mask, then the goggles or the face shield, and then after that, the gloves. And in between, you should use alcohol rubs. And, when you take it out, then you take, first of all, the gloves, followed by the gown, followed by the goggles and the face shield, okay, and then the mask and hand hygiene. Always, it's good in between. And we have that as a video, and we show it video, and it's actually on the nursing station. It's available. I wish that for a while we were showing it every day, but then things stopped, and I think we should activate it again. So please, our chief resident and our senior resident, it's actually, please show it on a daily basis, because it's a good reminder for all of us. Now, there has been a big, kind of debate, should we wear, why we're not wearing, kind of N95 at all the times, and in different occasions. But this is from the CDC, and if you look what it requires gowns, gloves, eye protection. Surgical face mask is as good as the N95. If you are in the urgent care or clinic, emergency room, in the inpatient setting, it's okay to have that as a setup. But if there is an area where there is a procedure going on that causes aerosolization, or the patient is admitted in a negative pressure room because of her or his, disease severity of illness requirement, then an N95 should be, we should wear N95. This is what is required. So a mask, a surgical mask, a goggles, or a face mask. And if you are in a kind of in aerosolized procedures, or in a negative pressure room because of the patient requirement, you need to wear your N95. Now, what are the aerosolized generating procedures? These are the bronchoscope, resuscitation, colonoscopy, endoscopy, high flow oxygen, tracheotomy, upper endoscopy, swallowing evaluation. They are all considered as aerosoloids generating a procedure. And in this case, we need to wear our N95. Your patient should be wearing N95, should wear a surgical mask. And even if they are requiring oxygen or CPAP, still you can put the mask on them. And in this case, that would decrease the spread. And lastly, please avoid touching your, your face, your nose, your eyes when you have your PPE on, or even when you don't have it, because in this way you contaminate yourself at a high rate. This is a very nice and useful video that actually tells you the don't and the from the NHS, and it's really nice and to the point. And so in summary, in order to prevent, we need to wash our hand, cover, cough etiquette, wash, clean the surfaces, stop the contact and keep our distance. And it would be really great if we keep, doing this PPE huddle for 10 to 15 minutes at our time to sign in and sign out. It could be part of our handover and as far